All right, I think we're going to get us rolling here. So before I turn over the presentation to our guest speaker, Ryan Madigan, let's go through a couple of ground rules. Number one, we are recording the event. We will have that available. We're going to so that'll be distributed potentially tomorrow, but if not, first thing next week. Also, we're going to be using the chat box to answer questions, and as questions pop up, go ahead, feel free to put that out in the chat box. I'm going to be monitoring that and happy to answer questions as they come up. Already in the chat box is an event survey, so that's live right now. So if you wanted to fill that out either while the presentation is moving along or at the end, that would be terrific. Love to get your feedback. And then this probably concludes the amount of material that I'm going to add to tonight. Our expert speaker, Ryan Madigan, has been a good friend of mine for over 20 years, has a real passion for Medicare and as well as Social Security. And so he's going to be doing the bulk of the presentation. So I just recently visiting with some clients. Ryan, you should be prepared for this. This gives you a good indication of the audience that you're dealing with. A client recently shared with me they had a neighborhood get-together at their house to discuss Medicare and Social Security. So that's the level of financial knowledge that you've got floating around in this audience pool. And at that get-together, they all enjoyed a glass or two of wine while they discussed Medicare and shared war stories among each other. So I'm taking a page from their book. So cheers. And I will turn things over to Ryan now.
All right. Well, thank you, Mark. Thank you, everybody who is taking some time out of your evening to join us. That neighborhood gathering is a first. I've not heard that before, so I'm impressed. As Mark said, my name's Ryan Madigan. I'm going to be walking through Medicare planning, giving you some updates on 2023. I always like to just state on the upfront that I come to these sessions without any expectation that anyone has a particular level of knowledge around how Medicare works and some of the considerations that go into making your decisions for your coverage. And so for some of you, components of this might be a refresher, and for others, this might all be completely brand new. And my goal is to give you the core information that you need, try and simplify that as much as possible. At the end of the day, it is still a government program, so I can only do so much simplification, but I will do my best here. But please do ask questions. We absolutely want to. I know I'm going to be covering a fairly significant amount of information in a relatively short amount of time. So if you've got questions, please throw those into the chat. Also, just know that we are happy to follow up with you individually. So if your question is something that's more of a personal nature that you don't want to ask in front of the group, please reach out to somebody at the Fairhaven team, and we will make sure that we get that question addressed as well. So I'm going to start with just a high-level overview of where we are from a beneficiary standpoint. I won't spend a ton of time on this slide. I think everybody knows that Medicare is essentially the main healthcare payer in this country and is the driving force for nearly 63 million people in terms of coverage. But a couple of things I do want to point out. First is that as we go through this conversation this evening, I'm going to really take us down two tracks that run more or less parallel to each other. But when you start thinking about how to get your Medicare coverage, you're going to hear me use terms like original Medicare, traditional Medicare, and then you'll also hear me use a term by the name of Medicare Advantage. And there are distinct differences, and we'll talk about some of the pros and the cons and the differences between those two programs. The front part of the conversation, I'm going to focus on original Medicare, which is what I call the unbundled approach. And then we'll talk about Medicare Advantage, which is more of a bundled type program that looks a lot like the plans you may have had either through an employer or through a private marketplace plan. But to give you a sense of how that breaks out, because there's a lot of different opinions out there about which way is better to go. Each individual it's important to understand that each individual's unique needs and preferences for how you would like your healthcare delivered may elicit a different approach. And also budgetary reasons might come into play as well. But as we sit today, about 60% of Medicare beneficiaries are in the original Medicare, which is kind of that unbundled approach to having your coverage. And then the remaining 40% have elected a Medicare Advantage plan. Now that's actually an increase. So we're actually seeing more and more people start to consider and or move into Medicare Advantage plans. And there's, like I said, there's some various reasons, and we'll talk a little bit about that. I think we all know that we're trying to effectively manage our expenses in retirement, particularly as it relates to healthcare. This is just a few high-level stats of some of the most common, per service, per visit expenses that many Medicare beneficiaries are paying as part of the services they receive. And the other thing I always like to just kind of point out is the top 5 most significant or most prevalent conditions, chronic conditions that are treated by the Medicare program. And so, these are probably not going to come as a huge surprise. They are certainly the most common type of conditions that I see as I'm doing individual consults, but just to kind of give you a sense of where some of those high level stats of Medicare, I wanted to share that with you. So let's talk about the alphabet soup. And really, I call this the core 4. A and B are kind of the core components, and we're going to talk about what those are: your hospital and your outpatient or doctor coverage. Your prescription drug coverage is Part D, and then we'll talk about Part C, which is commonly known as Medicare Advantage, which I referenced a moment ago. So let's talk about Part A. For most people, Part A is going to be a premium-free component of your coverage, meaning if you're fully covered for Social Security benefits and or you are married to a spouse who is considered fully covered for Social Security benefits, Part A is going to not come to you at a cost. That's because you've been paying that through your payroll taxes during the course of your career. Part A is your hospital or inpatient care. So this is going to be the component of Medicare that covers when you are in the hospital for extended period of time. If you are, let's say you have an illness, or you maybe have to go, you have an accident, and you ultimately require some additional skilled nursing care, Part A would typically cover that. Now, one thing I always like to point out, because sometimes there's some confusion, skilled nursing care under Medicare is not long-term care. Okay, this is for finite periods of time as a follow-up to typically having been in the hospital. The other thing this will cover is things around hospice or end-of-life care. If you don't have your full 40 quarters of eligible Social Security covered income on your earnings record, then you may be subject to a paying for Part A, and you can see what those premiums are. For 2023, and again, most of the numbers that I'm going to go through tonight are going to be for 2023 because we are, as of the 15th of this month, Saturday, actually, we're going to be entering into open enrollment. And so everybody's starting to take a look at what are my costs going to be for 2023. So heading into next year, the deductible for Part A is going to be $1,600. Now, the thing that's interesting about Part A is it operates a little bit differently than the other components that we're going to talk about when it comes to a deductible, because Part A operates on a benefit period basis, meaning if you go into the hospital, let's say in January, you're going to be subject to that $1,600 deductible. Once you're discharged from any inpatient care for 60 days, that benefit period closes. Let's say you had to go back in later in the year. You would have a deductible, a new benefit period would open, and that deductible would apply again. So it's possible that you could have a hospital deductible more than once in a given year. And we'll talk about ways to have that covered, but just be aware of, at the core, that's how that works. And I've had people that did not have, supplemental coverage, or I've had people that have been caught off guard by that before, where they were paying that deductible out of pocket. In terms of copays, so when you go in, if you are covered by Part A, and typically what that means is that you're in the hospital for generally 3 days or more. Okay, now don't think if you go into the hospital and they keep you overnight, if they have you kept there as observation status, that's not going to be covered by Part A. That's typically going to be covered by Part B. But for an inpatient, a true inpatient care, If you're in the hospital for the first 60 days, you're not going to have any copay. For days 61 to 90, you're going to share a $400 per day copay. And above that, you're going to dip into what are known as reserve days, and that is $800 per day. Okay. There are ways, again, through supplemental coverage or through an Advantage plan to get additional days with oftentimes lower coverage, or lower copays. But just to give you a sense of what that looks like under Part A at the core. Skilled nursing facility, first 20 days, Part A is going to cover. Then you're going to start sharing in some of those costs if you're in the skilled nursing facility for a longer than 20 days. Once you go beyond 100 days in skilled nursing care, and typically that's not, that's not going to be the case. They're going to probably come up with a different care strategy for you. But if you are in there, you're going to end up paying for full cost of that care to the extent that you're still in that skilled nursing facility. All right, Part B.
Hey,
Part
Ryan.
B. Yeah, go ahead.
We're already getting a couple of questions, so maybe before we go to Part B, if you are working and on Medicare, will the monthly premiums be different than if you are not working? Is it based on earnings in your particular work situation?
No, but we'll talk about working. So your premium is your premium. Now there are income related surcharges potentially depending on your income level, which I will talk about. And if you're working and covered by an employer plan, you also have the ability to defer enrolling in Medicare in most instances. And we'll talk a little bit about that a little bit later here in the presentation. But your premium doesn't change just because of you're either working or you're not. It's going to be driven by the income you're reporting on your taxes. And we'll talk about those surcharges. In fact, Part B is one of the components that is impacted by that. So your Part B, when you enroll in that, is going to be your outpatient care. Think of it as when you go see a doctor, your specialist, you need an ambulance, it's pretty much everything that's not done in the hospital. What's amazing, believe it or not, for 2023, the Part B premium was just announced that it's going down. That's the first time that I'm aware of that the premium went down year over year. And so Part B costs, because they had over-indexed for the cost of what they anticipated to be paying out for a particular service and medication last year, they over-indexed for that and were able to reduce the premium heading into 2023. So the standard premium is going to drop, I think it's by about 3% if my math is right, from 170 down to about 165 this coming year. The other component that has dropped slightly is the deductible. So Part B does have a deductible, and it is an annual deductible. So unlike what I referenced a moment ago, where I said, there's a per benefit period under Part A, under Part B, it's an annual deductible. So in 2022, it's $233. For 2023, it's dropping down a few bucks to $226. So that was a big shocker. There had been rumblings that, there was a potential for a reduction, but I don't think any of us really legitimately thought that the government was going to reduce premiums, but in fact they did. And of course, today you may have heard the news that they announced on Social Security side a nearly 9% increase in your benefit. So hopefully that'll help close the gap a little bit, particularly in the environment that we're currently in economically, close the gap a little bit in terms of out-of-pocket costs for some people. Now, you'll see in the middle box under cost, that second bullet point. Part B is a component of Medicare that is subject to what are known as income-related monthly adjustment amounts, also known as IRMA charges. In fact, Mark just recently, I think you did an email newsletter or something around anti-IRMA, the video, which was great. So IRMA charges are going to come into play if you are higher income individual or couple. I will talk about the specific brackets here in a little bit, but just be aware of the fact that your Part B premium could go anywhere from $230 to call it almost $560 in a per month basis based upon income and retirement. And I'll talk about how that works in a little bit. But there is a scaled component to the costs relative to Part B outpatient care. Part B works at a high level. In most cases, all of your preventative care is going to be included. It's an 80-20 split. So Medicare is going to pay 80% of the approved reimbursement costs. You are typically then going to be responsible for 20% co-insurance for Part B covered services. In some states, in some cases, that can be as high as 35% if a provider doesn't accept what's known as Medicare assignment. Medicare assignment is essentially saying, okay, I'm a doc, I'm going to take whatever the Medicare approved reimbursement amount is and consider that 100% payment for the services that I have provided. In some instances, you might have a doc that says, I'll take Medicare, but the reimbursement rate's not quite, I'm not going to take that as 100%. And at the federal level, they can charge up to an additional 15% of the Medicare amount. So that essentially would make your co-insurance amount as high as 35%. Now, some states limit that. So for example, New York, as an example, limits that. Other states have different restrictions around it. The reality is most of the docs in the hospitals and facilities, I very, very rarely see a doc when I'm doing a consult for a client that they're seeing somebody that does not accept Medicare assignment if they're participating in Medicare. There's certain concierge docs that don't take Medicare at all, but that's a separate component. But just be aware of that. 80-20 is the split. The thing you need to know about original Medicare is what people love about it is that there's no network. You don't have to get a referral. You don't have to worry about, is this doc in network or out of network? People love that. One of the downsides to original Medicare, if you leave yourself open to it, is that there is no out-of-pocket cap. So if you said, I'm going to enroll in A and B, I'm not going to do anything else, you could leave yourself open to a pretty significant out-of-pocket exposure. Now, we will talk about ways to cover that in a moment when we get into supplement plans, but just be aware when we're talking about just open-ended original Medicare, yes, there's no network, but you also have to make sure you put in some supplemental coverage because there is no out-of-pocket limit at the core of that coverage. I'm going to skip over C and we'll come back to that in a moment. But the third piece of Medicare coverage that's really critical is prescription drug. And this is probably one of the areas that I see the most either lack of appropriate coverage or overpayment among clients that I have worked with over the years. And the reason is, there's a lot of reasons for it. What you need to know is that Part D, even if you're not taking any prescription medications, when you enroll in Medicare, you need to have coverage in place, even if you're not taking any drugs. I've had people that have been told, well, you're not taking any meds, don't worry about it, just enroll when you think you're going to need a plan. The problem with that is that there's penalties involved, and we'll talk about those penalties in a little bit. But at the high level, prescription drug plans are going to be issued by private insurance companies. Now, there are some plans that are available broadly across the country, and there are some plans that are going to be geographically limited in terms of where they're offered and the insurer that's offering it. This is going to cover your prescription meds. It operates on what's known as a 5-tier formulary. The higher number in the formulary, the typically more expensive the medication is. So if you're in tier 5, you're typically going to be in a specialty brand name. If you're in tier 1, you're going to be in preferred generic medications. So a lot of times you can get those with little or no copay at all. The coverage phases in Part D, there's actually 4 of them. So there's the deductible, the initial coverage phase. You've got gap coverage. Now the donut hole, there's actually a typo in here. It should be deductible, initial, gap coverage, and then catastrophic, as you see on the slide. We'll talk about that. The donut hole was a big issue for people for many years, and that actually closed as a result of the Affordable Care Act legislation. But there are still a component of your coverage, depending on your medications that you're taking, where you may be subject to increased costs for a period of time. The average plan heading into 2023 is, in terms of monthly premium, is about $35 a month. But I have seen them as low as $7 or $12 a month, right? So there can be a wide variance in terms of the plans and the premiums out there, and that's why it's important to shop for these. The other thing I often see when I talk about, when I mention that I often see people that might be overpaying for their medications. Maybe when you enroll at 65, you're not taking any medications, right? You're healthy or whatever the case may be, and your health changes. But people think, okay, well, I enrolled at 65, the plan is still available, the premium's still reasonable. These formularies and the networks in which the pharmacies participate change every year. And so it's important, especially if your healthcare needs change, just like a financial plan. If something significant changes, you want to make sure that when you have the opportunity to review these plans at the end of the year, that you do that. Two that come to mind, I worked with two cases not that long ago where we did a review and we saved $3,000+ the subsequent benefit year just by changing the plan, because their medications were in different formularies or better covered by alternative options. So be very aware, especially for those of you that are taking medications on a regular basis, that you want to make sure you're reviewing this regularly. Similar to Part B, your income will drive additional costs. So IRMA costs also come into play as it relates to prescription drug. So while the plan is going to charge you a premium, if your income is high enough, Medicare is going to go ahead and say, okay, well, you can also share a little bit more in the cost for prescription medication. So that may be anywhere from an additional $12 to as high as $76 a month on top of the plan premium that you have enrolled in. And that is Part B and Part D are the two components where that IRMA charge comes into play. For 2023, the deductible is going to be $505. So that's gone up a little bit heading into 2023. On typically the way these plans work, it's a 75-25 split. Typically the plan is going to cover 75% of the costs. You oftentimes will be responsible for up to 25%. And then if you happen to fall into a category that is known as catastrophic coverage, that drops down to typically about 5% is what you're going to be paying for medication costs beyond a certain threshold. And let's talk a little bit around what those thresholds are. So every plan is going to be a little bit different. No plan will have a deductible in 2023 that is more than $505. Some plans don't charge a deductible at all. Some plans have a lower deductible than that. Many of them don't assess the deductible for medications that are in Tier 1 or Tier 2 formulary. So basically, they're, if you're in a commonly prescribed blood pressure medication, you're probably going to be able to get that for low or no copay, and the deductible won't apply to it. If you're in, let's say, a specialty medication for a cancer treatment, as an example, deductible is going to apply. And of course, you're going to be in a higher tier formulary, so your out-of-pocket costs are going to be higher. For this coming year, the initial coverage limit is essentially what the plan covers. So up to $4,660 of what you paid out of pocket and what the plan and Medicare have paid for medications, that's your initial coverage limit. Once you get up to that amount, you're then what's known as gap coverage. So what happens there is that as a result of the Affordable Care Act, there were some significant discounts that came in and closed the donut hole. So that's where that 75-25 split typically is going to come in. Generally, the plan and Medicare are going to, or excuse me, the discount and the medication provider are going to pay roughly 75% of the cost. You're going to be responsible for 25%. If your out-of-pocket expense for the year exceeds $7,400, you'll then be in catastrophic coverage. And that's where that 5% coinsurance for everything past that comes into play. Hopefully none of you fall into that. I often have people ask, well, I can't imagine having $7,500 in out-of-pocket costs for medications. You'd be amazed. Depending on how your health condition, but depending on the particular treatment that you are under, there are some medications that rack up very, very quickly. I have worked on cases in the past where both spouses were essentially through gap coverage by the end of the first half of the year. Okay, there's actually two medications for hepatitis treatment, which, believe it or not, in the boomer generation is not all that uncommon. So there are two medications that are anywhere between, call it an $80,000 to $95,000 12-week regimen. So think about every time you swallow a pill, it's $1,000 more or less. That's going towards the plan costs. Medicare covers it because it does stop liver failure or liver damage. But again, some of those medications just for a short stint can be very, very expensive. A couple of things I wanted to point out. As a result of the Inflation Reduction Act, that legislation that was recently changed, insulin in 2023 is going to be capped at $35 a month for all Part D plans. Now, this is not necessarily new. You might recall that $35 insulin was actually implemented by the prior administration. It was then removed, and now it was added back in the recent Inflation Reduction Act legislation that was passed. So previously, there were plans could choose whether or not to participate. Now it's going to be across all of the prescription drug plans. So if you're somebody who is in need of insulin, that's going to be a significant savings for a lot of people heading into the next year. The other thing that came out is that Medicare expanded coverage for vaccines. So many of these that you see on the screen were covered before, but the big one that was not, that I often heard from clients that they were like, why is this so expensive and why isn't it covered, is the shingles vaccine. That's now going to be covered without any without any co-sharing or copay having to be paid for you. It's going to be covered under the plans heading into the new benefit year. So a couple of items I wanted to point out in terms of cost savings. So we've talked about everything up to this point, again, has been original Medicare. So the unbundled approach. As I mentioned earlier, if you go with original Medicare, people love it because there's, again, no cap, or no network. They don't have to worry about it. You can go anywhere they want. Especially works very well for people that might have doctors in multiple states that might be splitting time between states. So let's say Illinois is your primary residence, but you're going to go down to warmer climates in the winter for 4 or 5 months, and maybe you've got some doctors that you're going to see while you're down there for non-emergency care. Typically, if you're in a plan with a network up here, those docs down there are going to be out of network. So either you're going to be paying an increased cost, or if not all of the cost, depending on the type of plan you're on. Under original Medicare, you don't have to worry about that. You can go anywhere in the country. If you go with original Medicare, so we've talked about A, B, C, and D, you're going to want a supplement plan. And so now we got A through N, right? So this is what confuses people. I won't go through this whole chart, but I will highlight the plan that I typically recommend, that I believe gives you the most broad coverage and gives you the most risk control in terms of out-of-pocket exposure during the course of the year if you had significant healthcare costs. So the G plan, G as in George, that middle column, you can see covers everything except the Part B deductible. So at this point, if you become newly eligible for Medicare, there is no longer a plan that you can purchase. Some of you might be grandfathered into an old plan that does cover the Part B deductible. But going forward, all plans no longer cover the Part B deductible. So heading into this coming year, remember, it's $226. But other than that, that benefit period deductible for the hospital, the co-insurance amounts for Part B, all of those costs for A and B would be picked up by your supplement plan under a G plan here, okay? So that's going to be, again, 20% co-insurance, the Part A deductible per benefit period, any cost sharing for being in a hospital or skilled nursing facility, all of those types of coverage. Across the country, broadly, if you're looking at Blue Cross, let's say, for example, Blue Cross's G plan versus Aetna's versus Humana's versus AARP's, which is United Healthcare. If you're looking at their G plan, at the core, it's going to be the same coverage. This is all standardized. Now, there are some states that have a different version. So Wisconsin, Minnesota, and Massachusetts have a slightly different version of supplement plan coverage in those states. But a lot of times, like Wisconsin, for example, my dad lives up in Wisconsin. They have a core plan, and then you can bolt on additional components to make it look pretty much like a G plan, which is nice. So they just do it a little bit differently up there. But broadly, most of the time, and here in Illinois in particular, if you could look at all the different G plans, you're going to be looking at standardized coverage. Now, some of the insurers will offer additional wrap-on benefits, i.e. dental, vision, or hearing coverage that you would pay an additional premium for. But at the core, these plans are going to be standardized. The one thing you want to be aware of, when you first get into Medicare, you have a guaranteed issue right. So during your initial enrollment period, or if you qualify for a special enrollment period, if you deferred enrollment because you were still working, which we'll talk about in a moment, you have guaranteed issue rights, meaning you can purchase any plan. They can't charge you more, can't put you on a waiting list, or put you on a waiting period, or exclude coverage for a pre-existing condition. Basically, there's no medical underwriting. Once those rights are no longer there, let's say a year down the road, you're like, well, I went with an N plan, but I really wish I had gone with a G plan, and you want to switch. Not to say that you can't, but if your health has deteriorated, or if you've got a significant pre-existing condition, they then can now ask you to go through some medical underwriting questions, and that can preclude you from getting access potentially to the plan that you want to get into. It could cost you more, and you might be stuck in that. So shopping for these up front is really important. The nice thing with supplement plans is you can shop for them at any point in the year. You don't have to wait until open enrollment like you do most other parts, but it's really, really critical that you're aware of shopping for the right plan at the right time, particularly if you have health conditions that would potentially cause problems without those guaranteed issue rights. Now, some states have, continuous or ongoing guaranteed issue rights, and you can see that. Connecticut, Massachusetts, Maine, and New York have different variations. But broadly, you want to be mindful of that as you're thinking about a supplement plan and which option to go with. Let me pause there for a moment, Mark. Are there any questions in the chat?
Yeah, actually, I've got a question. So
Yeah.
as mailers are coming out this time of the year, for somebody that's shopping for a G plan in Illinois, let's say, is pricing the same? The cost of the plan that I'm going to pay, is that the same no matter who I might work through to get my coverage, or do costs of the plan vary depending on who? Is there some kind of markup?
Yeah, no, great question. So the insurance companies themselves will set their premiums, right? So I've seen variances of $50-$60 a month in some cases between one company's G plan versus another. Now you're getting the same coverage, right? So at the core, and so that's important. Things you want to be mindful of is a reputable insurer. Do they have a good track record, right, in terms of Medicare, being a Medicare provider and paying claims? Do they have good customer service ratings? Do they have also, what do their premiums look like over the last couple of years? Now, sometimes you can't see that outright, but either talking to an agent or talking to a consultant like myself, we can generally give you some guidance around, hey, this company's had very good track record, and their premiums have been, their premium increases have been relatively stable. But there's absolutely a difference. You could have, insurer A charging $150 a month for plan G, and insurer B charging you $120, right? So that's where you really want to be mindful of that, because if you're getting essentially the same coverage, that's where you want to really be thinking, well, why would I pay the extra $30 a month if you're not getting anything more for that coverage?
Another question came in that somebody's in an Illinois plan G plus plan that also includes a few other things like dental and gym membership and things. So the chart I'm imagining the chart is not meant to be exhaustive of all the various benefits.
No, and that plus plan, I suspect they are referring to the Blue Cross Blue Shield plus plans.
They are.
So that G plus plan is relatively new in the last couple of years with Blue Cross. It's actually a very nice add-on, but that's what I was referring to earlier. So you've got the G standard plan that they're paying for, and then they're paying an additional premium for that dental, vision, hearing, and gym access network. I will say, though, for those types of benefits in the senior space and the retiree space, Blue Cross has actually been pretty competitive in terms of the premium they charge for those additional services, but that would not be considered standardized G or any other supplement plan coverage.
So I've got an IRMA question. Should I hang on to that one until we
hang on to that one for a minute, because we're going to get to the tables in a second. We'll talk about how that works. Anything else before I jump into the next part?
I think we've covered everything so far. It's the IRMA on deck question.
All right.
Yeah.
Hold that one. I will get to that here momentarily. So everything that we've talked about up to this point, as I said, was original Medicare, the kind of what I call the unbundled approach. The alternative option is to go with what's known as a Medicare Advantage plan. Now, if you go with a Medicare Advantage plan, that's going to typically include your prescription drug. It's going to include, more or less the components of a supplemental plan in there, right? So you're not buying those pieces separately. Everything's going to be bundled in. You're still enrolling in A and B through through the Social Security Administration. But then you're selecting an Advantage plan that is going to include prescription drug. It's going to include supplemental. Many of them, what people like about them is that they also will include things like dental, vision, hearing, access to silver sneakers, which is the gym membership that you can go to. A lot of times Medicare Advantage plans will cover things like an Uber ride to the doctor, food delivery to your home. Some of them will cover things like having a home healthcare nurse come to you, where original Medicare, let's say you're somebody that needs an infusion every month that has to be delivered by a medical professional. A lot of times an original Medicare, you're going to have to go into the office, right, for that medication. Well, depending on the situation, an Advantage plan may pay to have or cover a home healthcare nurse to come and do that in your home. So it's just, there's pros and cons to where you'd like to go. And I think that's also part of the reason we have seen more people look at Advantage plans, just in terms of the benefits that come with that. Now, the thing you need to be aware of is that when you decide to go with an Advantage program, you're now essentially saying, I'm willing to play within a network. So these plans look the most like the type of coverage that we've grown up with, whether it's through our employer or through a private individual plan, if you were buying that out on the marketplace, right? And maybe that's another thing that people like about it, is it's one phone call instead of having 2 or 3 potentially different insurers for my different components of coverage. With an Advantage plan, you're calling one insurer, but you're going to play with either an HMO or a PPO network. I tend to steer away from and advise against HMO networks. There's a lot of really good PPO plans out there. With an HMO plan, they're either in network or they're not. And if they're not, you're typically paying all of the costs to go see somebody who is not in that network. And of course, many of them also still require referrals for specialists and things like that. If you go with Advantage, I would recommend a PPO, which is going to have in-network and out-of-network benefits. You're going to pay more for out-of-network coverage, but at least you have that. The networks tend to be pretty geographically limited. So for example, if your home state again is Illinois, you're not going to see doctors down in Florida as being in network on a plan that's here in Illinois. Okay, those are going to be out of network services. And in fact, some of the plans could be very specific to a healthcare group like Advocate Healthcare is where you're going to get most of your in-network docs, or DuPage Medical Group or Northwestern, whatever the case may be. There are some plans that are going to favor particular medical groups over others in terms of being in network. So that's where it's critically important for you to know which facilities and which doctors that you want to have access to are in and or out of network in these plans. The premiums for them are going to vary. And this is probably where people really like the Advantage plans. So you're going to pay your Part B premium the same as you would. And if you're subject to those IRMA charges, you're going to pay that regardless of whether you choose an Advantage plan or not. However, many of the Advantage plan providers will charge a low or no premium for all of that additional care. So you pay that $164.90 is your base premium in 2023, and you might be able to select an Advantage plan that has no monthly premium above that. So it's very cost effective, where you're getting your prescription drug, you got your A and your B, and you have the supplemental coverage and all these other services all packaged into one plan that doesn't cost you more than your Part B premium. So that's one of the things people like about it. The way that you pay and your out-of-pocket exposure is going to can be pretty dramatically across the plans, which is why you really need to be aware of that. It could be co-insurance amounts. It could be a co-payment type arrangement. It could be a combination of the two. By law, these plans do have to have an out-of-pocket cap. So in 2023, the max in-network out-of-pocket limit, so no Medicare Advantage plan can have a limit above $8,300 for in-network services. That jumps up to $12,450 for in and out of network services. So like if you went and got all of your care out of network, which you would never want to do, but let's just say you did, the max that you out of pocket you'd have there is $12,450 in 2023. That can vary by plan. Some plans will have an out of pocket cap of $5,000 or $6,000. Some of them might be as low as $3,950. It really just depends. So you want to be mindful of that and where that comes into play. But just like in your plans today, once you hit your out-of-pocket limit, the plan steps in and pays 100% of the costs for any care that's needed beyond that point.
Ryan, so
One thing
with
I'll point out at the bottom of the screen, you'll see you have a 12-month trial right. So the first time you enroll in Medicare Advantage, you have basically 12 months to say, you know what, it doesn't really work for me. I want to go back to original Medicare, and you can do that. And you've got those guaranteed issue rights that we talked about previously. So you get that, essentially one time. The other thing I'll say is that if you decide to, let's say, start with original Medicare, you can always switch to Medicare Advantage in the future. You're not stuck with what you choose at 65. 2 years later, you could say, well, I want to go to Advantage now, and you can do that during open enrollment. So just be aware that you have flexibility. But again, as we talked about earlier, if you say, hey, I'm going to start an Advantage, and maybe 2 years from now, I want to go back to original Medicare and I want that G supplement plan, but you know what? Maybe you just came off of a bout of cancer treatment. That's going to be one of the first questions they ask. And so that could limit the plan that you have access to on the supplement side, which is why, again, you just want to be mindful of that when you're shopping for them. But the Advantage plans, I have a lot of clients that have gone with them, and they love the coverage. All their docs are in network. They like the additional benefits. They like especially the dental, vision, and hearing, which is not part of original Medicare, which would be one more thing you'd have to go shop for if you wanted that kind of coverage. And so there is a place for these, and they are becoming more and more popular. So let me stop there for a second, because I know I covered a lot.
So Ryan, with Advantage, so is there a need for supplements?
No, if you choose a Medicare Advantage plan, you are not purchasing a Medicare supplement plan.
Okay.
Yeah.
Okay.
Yeah.
And
you also typically would not be purchasing a separate prescription drug plan either.
Okay. And again, the switching between the two, you get that 12-month to move from Advantage back to Medicare.
Yep.
But then
One
after
time.
that,
Yeah.
One time. Gotcha.
Yep.
Okay.
Yep. Okay. All right. So let's talk about enrollment real quickly. How are we doing on time? All right. I won't spend a lot of time on enrollment here, because there's a lot of different periods that come into play. The big one is that your initial enrollment period starts 3 months prior to and ends 3 months after the month you turn 65. So you essentially have a 7-month window to get into Medicare. Depending on your coverage situation, typically you want to make sure that you enroll in those first 3 months so that your coverage starts at the beginning of the month that you turn 65. Okay. If, however, you defer or you wait a little bit longer, your coverage will then start later. So you want to make sure that you plan that so that you don't have a gap in coverage. So let's say you enrolled at 65 in 1 month. Well, then your coverage is not going to start for 2 months later. So you want to make sure that you've got that in place. Every year between October 15th and December 7th is the annual enrollment or annual election period. That's what we're coming up on this weekend. This is when you can make changes. This is where you can change your prescription drug plan. This is when you can go from original to Advantage, or from Advantage back to original. Again, you can make those changes every year. Once you're in Medicare, you're going to start getting, as we head into the fall, you'll get what are known as annual notices of change. That's where you really want to look at that to see, was the premium changing? Are my medication costs going to be changing? Any of those types of things. Unfortunately, so many people file those letters in the circular file and don't realize that their medications, as an example, might be 20% more expensive until they go to fill it in January or February of the following year. And then they're stuck with that plan for another benefit period. So be aware, this is the time when, if you're already in Medicare, you really want to take a look at your coverage. Doesn't mean you're going to change plans every year, but you just want to be aware of the different options that might be available to you, because they do change each year. And then the lower right-hand corner, I won't spend a lot of time on this, because generally my hope is that you're never doing anything between January and March. If that is the case, let's say during general enrollment period, that means you missed your initial enrollment period or your special enrollment period. So you had to wait until general. Your coverage won't start until July, and you may very likely be left with a gap and where you're self-insuring or self-paying for all of your healthcare coverage during that period of time, depending on your situation. So you don't want to find yourself in that position. You want to make sure you're getting into Medicare at the appropriate time. But they also recently made January to March a time when you can change your Advantage plan. So if you didn't make a change during open enrollment and you're in Medicare Advantage, that during January to March, you can say, oh, well, I want to go from one Advantage plan to a different one. You can't go back to original Medicare during that period of time, but they made another window where you could change from one Advantage plan to another. Again, typically, ideally, you're not doing anything between January and March. You've already made your decisions and you're effectively covered by that point in time. All right, so let's talk about a couple of special considerations. Questions I probably get the most around is, well, I'm 65 or I'm older than 65, or I'm coming up on my 65th birthday, I should say. I'm still working and I'm covered by an employer plan, or my spouse is covered. We're covered under my spouse's plan. Do I have to get into Medicare? Typically, you do not have to get into Medicare if you or a spouse are still actively employed and covered by an employer plan. For plans that have more than 20 full-time employees, those are considered large plans. They can't kick you out. There are some, for small employers with less than 20 full-time employees, it is possible that could become a secondary coverage plan to Medicare. You need to check with your HR or whoever handles your benefit program if that's your particular situation to see how that works. But for most larger employers, you can defer enrolling in Medicare. When you ultimately lose that employer coverage, you'll have a special enrollment period, which gives you an 8-month window to get into Medicare. And at that point in time, you still have those guaranteed issue rights. You can still get into the supplement plan, everything that we talked about before. But you just want to make sure you coordinate that effectively so that you are not left with any gap in your coverage once you know that your employer coverage is going to be lapsing. The one thing I'll point out, particularly for spouses, is don't assume the employer plan is automatically better than what you could get in Medicare, because a lot of times that's not necessarily the case. In fact, even in my own family, I've had situations where I always talk about my mother and father-in-law. Well, they retired at different points in time. My mother-in-law was covered on my father-in-law's plan. It wasn't a great employer plan. Premium was expensive. The deductibles were high, et cetera. We actually did the analysis, and it made sense for her to drop off of my father-in-law's plan because she got better coverage at a lower cost in the Medicare program. So it doesn't mean it doesn't make sense to do that, but you want to make sure that you're at least aware of your options and don't just assume that the employer plan is automatically better. The other thing I'll point out is that if you are somebody who is contributing to a health savings account, so you're in a high deductible plan, you're going to stay on that with your employer, you want to continue to contribute to the HSA. If you are going to continue to contribute, do not enroll in any portion of Medicare, including Part A. A lot of people will say, well, you got to get in Part A, otherwise you're going to have a penalty. That's not true. As long as you're fully covered, you can even defer Part A enrollment. And you would want to do that if you continue to contribute to the HSA, because once you're enrolled in any part of Medicare, you can no longer make a contribution to that plan. So just be aware of that. And depending on how your age, there can be up to a 6-month look back when you ultimately enroll in Part A. Now, if you're already receiving your Social Security benefits, you'll automatically be enrolled in Part A at 65, and you cannot undo that unless you stopped your Social Security benefits, which most people don't, right? But just be aware of that. If you're an HSA, you want to be very mindful of that, because if you over contribute with that, especially with that look back period, you got to get that money out before the next tax filing deadline. Otherwise, you run into potential tax penalties. So just be aware of that component.
So Ryan, just a clarifying question. So when I turn 65 and I want to stay on my employer plan, I should not sign up for Medicare 3 months prior to my 65th birthday.
You don't need to. Like, if you're to stay on that employer plan, you typically are not going to enroll in Part B, right? Because then you're just paying for duplicative coverage. Right? You're not going to pay that premium. Now, take out the HSA piece that I just spoke about. If you're on a traditional PPO plan and you're coming up on 65 and you're going to defer enrollment and stay on the employer plan, that's great. Don't enroll in Part B, but it doesn't hurt to enroll in Part A, because Part A then becomes a secondary coverage for inpatient services behind the employer plan. So, and because Part A is, without premium for most people, it doesn't hurt to have that. It's just that HSA rule where you need to be mindful of that when it comes to the Part A enrollment. Okay. All right. I I won't spend a lot of time on COBRA. I get questions around this, but it is important to know COBRA generally does not make sense to keep. And whether or not you get to keep it with Medicare really depends on your age and when you become eligible for COBRA. The one thing I do want to point out, and I always do here, is that even in some rare instances, it may make sense whether you're going to be bridging a gap in coverage for supplemental coverage for a period of time. If you, for example, in fact, I had a case recently where one of the spouses had very expensive medications that were tier 5 in Medicare, and we're at the end of the year, and the coverage for those medications were going to be less in COBRA, even with the COBRA premium. So they were going to keep that for a couple of months to fill those meds before moving into a supplement plan. But generally, you do not want to keep COBRA. It's going to be expensive. COBRA is a secondary payer to Medicare. You still have to roll in your A and your B, but just be aware of some of that coordination. If that's something you have a question around, happy to chat with you about that. But I won't spend a whole lot of time on that, just other than to say COBRA generally does not make sense. All right, Irma. Now we got your question that's on hold. Go ahead, Mark, with your question, and then maybe it'll tie into the chart here.
And I've got a couple of follow-up questions. So if I'm still working and I'm on the employer plan, what's the process to enroll in Part A?
Okay.
And if I decide to stop working 6 months after my 65th birthday, can I then enroll in Part B?
Yes. So the first part is, first of all, everybody should, if you haven't already enrolled and set up your online Social Security account, you should absolutely do that. They're pushing a lot of stuff out to the online systems. Social Security Administration is actually the overarching entity that manages Medicare. So you, believe it or not, you enroll in Medicare through your Social Security account. You can call in to an agent or potentially try to get an appointment, an appointment at an office. But generally, I tell people to do it through their online portal. So you can go in and you can enroll in Part A only. And I'm happy to share a kind of a quick snapshot guide as to how to do that for anybody that's interested as a follow-up. You can go in, enroll in Part A only. You're just going to defer your Part B. You're not going to enroll that right now because you're covered by an employer plan. When you ultimately lose that employer coverage, there will be a form. It's an employer information form where your HR department will sign off and say, yes, Mark's been covered by this plan from X date to Y date. And that will make sure that you don't run into any potential penalties for having not been in Medicare because you've been covered by a credible employer plan while working. And what was the other question?
Then I've got the IRMA one that's been on deck.
Okay.
So
How it works?
Why don't we do that? Why don't we, before I ask that, why don't you go ahead and run through how it works?
Yeah. All right. So the IRMA charges, as we talked about earlier, are income related. So as you can see here, and I won't read every one of the brackets here for you, you can see it on the screen. But what they're doing is they're looking at your return from 2 years prior. So for 2023, they're going to look at your 2021 return, and that's essentially your adjusted gross income, plus they are adding back in any tax exempt interest, just like they do for Social Security taxation. So keep in mind, if you've got a significant municipal bond portfolio that's kicking off some nice interest-free income to you, that while you're not going to pay taxes on it, it will get added back into the brackets that you see here on the screen, and where they will determine whether or not you are subject to an IRMA charge. So for a married couple filing joint, as long as your AGI is below, or your reportable income is below $194,000 heading into 2023, based upon your 2021 tax return, you'll pay the standard Part B premium of $164.90, and you will not pay any IRMA for Part D. Once you go above that, you can see how it stair steps up. And depending on where you fall in that bracket. And again, this is always an opportunity, especially if you're right on the bubble. Mark and the team are really, really good about taking a look at these brackets as well and doing what they can as part of your financial planning efforts to potentially keep you under those brackets. But that's where you need to be mindful of that. And keep in mind, if I didn't say it on the front end, Medicare is an individual insurance program. So everything I have gone through is per person per month. And these brackets are per person. So you need to be aware of that's not $230 family premium. That is, for a couple times 2. So you need to be aware of that, and also just be cognizant of the fact that yet another bracket comes into play when it comes to planning and retirement.
So I think that's a good lead into the question. So the question is, if IRMA is a rolling target, so the 2-year look back, why do we get a chance to apply to potentially reverse it? So for example, my 2021 income taxes were unusually high. Might that result in an IRMA adjustment for me 2 years from now? And if so, why and how can I challenge that?
Yeah, so there are certain situations that you can appeal that. I'll use a very common one. Let's say let's say you retired in 2022. Your 2021 income, typically as people are retiring, right, they're at their higher levels of income. Well, retirement, either a reduction in hours or full-on retirement, are a eligible life event to appeal and ask for a review of the IRMA charges. So let's say your income was $250,000 in 2021, but heading into 2022, this year, you had your Social Security and whatever you pulled out of the portfolio, you're going to be below that. You can, as a result of retirement, ask for an appeal, and they will oftentimes waive that surcharge. However, they are always looking at your tax returns. So what that means is, let's say you sell a vacation home 4 years down the road and you got a big cap gain on that. Okay, they're not going to waive your IRMA charge because of the fact that you sold your house in Florida. So you could potentially see that catch up with you, right? Depending if it puts you into an IRMA bracket. And then, of course, it would come back down in subsequent years based upon your tax return. So there is a little bit of a gap there, and there are instances where you can apply for an appeal and ask to have that reevaluated, but it's not a blanket just because you feel like your income was higher. There has to be a legitimate reason to do that.
Okay, so more questions on this. So do they look at this? So I'm retired and I'm 8 years into retirement. Is this something that they're looking at every year?
Yes.
Okay. Yes.
Yes. Yep.
And then what is the appeal process? Is that is that also through Social Security, or how does that work?
There's a form that you can apply, that you can fill out. If you want to go through an appeal process, I often recommend calling in to Social Security as well to talk to an agent about that. But there is a formal appeal process by which you can request a reevaluation of any IRMA charges.
So does charitable giving, does that help? So in an unusually high income year, would that be a reason to accelerate charitable giving to help drive down?
Yeah, absolutely, potentially anything that would drive down that AGI number is going to help, right? So if you know that you're going to, you've got a significant whether it's a big cap gain or whatever the case may be, yes, there are definitely things you can do from a planning perspective to keep your reportable income on your tax return lower and in the lower bracket. You may not, some people might say, well, I can't get below the 194, which, okay, fine, but you might get from 428 down to 230 in terms of your monthly Part B premium, right? If you can drop down, depending on the types of giving that you're doing or, the other planning that you're doing. So absolutely be mindful of that.
Okay, super.
All right. Any other questions on that?
That is it.
Okay. All right. I'll touch very briefly on late enrollment penalties if you don't get in at the right time. I don't so much see this very often for Part B, but if you, let's say, went, for every 12 months that you should have been in Part B and you weren't, and you didn't have, a reason or creditable reason to be deferred on your Part B enrollment, that's a 10% incremental penalty, and that is a permanent penalty for as long as you are in Medicare subsequently. The one that I do see or have seen, it's not all that uncommon, is around prescription drug. So if you don't enroll, as I mentioned earlier, you might say, I'm not taking any medications, I'm not going to get in a plan right now. If you did that, after 63 days without creditable prescription drug coverage, you start accruing a 1% per month premium penalty or enrollment penalty, which ultimately, let's say a year down the road, you enroll, you'd essentially have call it 10% permanent premium penalty on top of any IRMA charges on top of whatever the plan premium is. So you want to be mindful of that and why it's critically important to just make sure you have creditable drug coverage. But again, I don't see these a ton, but prescription drug is one that in fact, I did a session a couple of years ago, and there are 3 people that came up afterwards that were like, I haven't had prescription drug for 2 years. One of them hadn't had prescription drug for 3 years. And so they were wondering what that was going to look like. And we had to kind of talk through that a little bit. So, all right. So let's go through a quick case study and I'll wrap up with this. I know I've covered a lot of information and we're almost we're at the top of the hour. So I'm going to run through this fairly quickly, but I just wanted to give you a sense of, different coverage options that you have and what that might look like. So let's just say individual falls, Bob falls, he's 70 years old, requires a hip replacement surgery. He's going to be in the hospital for 4 days and he's going to be discharged out to a skilled nursing facility for 30 days. Assuming he lives in Chicago, paying the standard Part B premium. I pulled some of these estimated fees. This is really kind of more in line, not necessarily would be billed through, but more in line with, kind of average what potentially the Medicare reimbursement rates would look like. I'm not even going to look at prescription drug coverage, and we're not even going to really look very deeply into the follow-up care, right? Let's just look at this particular instance to give you a sense of what out-of-pocket expenses might look like. So let's say he had went with original Medicare, but did not choose a supplement plan. So for the year, he's going to pay about $19.78 for the Part B premium. He goes into the hospital, he's going to have the deductible, he's going to have the copay for the skilled nursing facility time. He will certainly hit the deductible for Part B. He'll have another call at $1,100 in coinsurance, at least for Part B costs. And so his total expense is already up to almost $7,000, $6,900 roughly. And without a supplement plan, there's no cap on that. That's just a rolling clock. And he's going to have follow-up care. What happens if he needs to go in to have, another procedure, whatever the case may be. That's why you really don't want to have original Medicare without any supplement coverage in place. Now, had he selected that G plan, he's still going to pay the Part B premium, but now we're adding $140 a month in what's known as a Medigap, or the Medicare supplement plan. So he's in a G plan. He's going to pay more in premium each month, but with this particular injury and fall and surgery, hip replacement, now the supplement plan's picking up the deductible and the copay. He'll still pay the $226 for the Part B deductible. Now he's done for the year with that. He's now at $38.84 for the year. And he's already hit the Part B deductible. And this is why people love original Medicare, because for all intents and purposes, outside of prescription drug costs, as long as the rest of his care is Medicare eligible services, the Medicare program and the supplement plan are picking up those costs for A and B. Okay, so that's where people like that, because it's like, you know what, I'm going to pay a little bit more in premium, but I know that my out-of-pocket exposure is limited. And I also know that I've got a network that I can go anywhere in the country. If there's a specialist I want to go see in another state, I can do that. I don't have to worry about whether or not they're in or out of network. As long as they take Medicare, I can go to them. The third option he might have selected is an Advantage plan. So this is a plan that actually provides all that coverage without any additional premium. So he's still paying the Part B premium, but he has an Advantage plan. So he didn't have to buy a prescription drug. He didn't have to buy a supplement plan. The way that the cost sharing and copays work in this particular plan, he does not have a deductible for the A or the B costs. But when he's in the hospital and the skilled nursing facility, he's going to have about $3,000 in out-of-pocket costs under this plan. Another $800, call it, for medical costs under Part B. So he's, for the year, about $5,800 out of pocket. Now this plan, when I put this report together, this plan had a $3,950 in-network out-of-pocket limit. Okay, so he hasn't quite hit that yet. So if he were to hit that, his total out-of-pocket cap for the year for medical expenses would be $59,2880. After that, the plan's picking up 100% of the costs. Again, the only thing that is not going to be 100% covered are the prescription medication costs that we talked about earlier, but I didn't factor that into this analysis. But 3 very different ways that he could select coverage, 3 different outcomes. One could argue that, hey, the G plan was way expensive. Let's say he went in and got his annual physical and didn't need anything else for the year. You could say, well, he overpaid, versus the Advantage plan that would have only been, call it, $2,000. But again, this is where you need to balance your preferences, your needs, the coverage that you want, and the amount of out-of-pocket exposure you potentially could be opened up to based upon the coverage that you choose. So I'm going to stop there. I know I've gone a little bit longer than we anticipated, and I appreciate that. And hopefully this was helpful. And I will open it up to any questions that might be still coming in.
Yeah, we got a few more. So can you defer Part D if you are working on so if somebody working on an employer plan and then sign up for Part D when you stop working?
D as in dog?
D as in David. Yes.
D as in David. Okay. Yeah. So as long as your employer plan is providing creditable prescription drug coverage, which most of them do, you can defer that. But you would want, if you're going to stay on the employer plan, you would probably defer both B and D because the employer plan is going to be providing that care. If you decide you want to go to Medicare, then you would unenroll from your employer plan and make the transition into the Medicare system, if that made sense for you.
And then so sorting through the information, we've gone through a truckload of information, but sorting through the information, evaluating costs, what makes sense for me individual. Is that a fair description, Ryan, of what you do for people?
It is. I don't sell any insurance plans. I am not an insurance agent or broker. It is purely a consulting opportunity to help you identify your needs, help you identify the plans that are available. I like to have no horse in the race and help people find the right coverage based upon their specific needs and situation.
So then based on that, I'm gonna answer this question. So another question is, where's the best place to find information, costs, et cetera, for different plans? So that's going to depend. If you are a Fairhaven client, you have access to Ryan, and so that would be the place to go. If you're not a Fairhaven client, first, shame on you. What in the world are you doing? But if you're not a Fairhaven client, so Ryan, if somebody's not a Fairhaven client, or for whatever reason they just find the two of us just intolerable, where would somebody go to get this information on their own?
Yeah, so there's a lot of information at medicare.gov, right? So you can go, there's the plan finder that is at the Medicare website. And I've actually done a nice job of improving that over the years. So you can definitely go there and start to get a sense for the plans that are available in your area. You just want to be mindful when you're going through that you do input the right components, especially when it comes to prescription drugs, especially when it comes to when you're looking at doctor networks, things of that nature. It can be a few clicks to get to some of that information, but there's a lot of great information on the Medicare site. Certainly there's a lot. I'm sure you're getting bombarded by different insurance providers and or independent agents. Those can be great places to go look. And then every state has what's known as SHIP, which is the Senior Health Insurance Program. So it's volunteer run, but it is funded through Medicare, or each state funds it. You can call the local SHIP number in Illinois or whatever state you happen to be in, and they can also answer questions for you and point you in the right direction as well.
So Ryan, could you do me a favor? I can't believe I'm going to say this. Could you tab the presentation forward so that people can see the disclosure, so we can keep the
absolutely.
We can keep the attorneys happy while you're doing that, which is not easy to do, by the way. But while you're doing that, another question: if someone's healthy, then which plan is good, Advantage or Original? I'd say maybe I'll answer that. That feels a little broad. It's probably worth a conversation with somebody like Ryan. Is that a fair answer, Ryan?
Yeah, absolutely. Certainly both are very good programs. It really comes down to what's some of the variables and the things that are most important to you. I will say, just my personal opinion, I tend to prefer Original Medicare, at least at the outset for people. Sometimes, that can be, difficult from a budgetary standpoint, depending on people's situation, depending on, especially the costs around maybe supplement and piecing all of that together. But I like the fact that there's no network. I like the flexibility around that and having a little bit more of a firm stopgap in the out-of-pocket coverage. But I also understand that there are certain things you have to then go and bolt on, right? So if I want dental, vision, and hearing coverage, right? So I got to go find plans for that. And so, there's just different ways to put it together. And sometimes, original Medicare can be a little bit more of a quote unquote administrative burden, right? Because you got potentially multiple insurers out there, but it's very much an individual choice. And you really want to look at both options as you're considering, so that you kind of know and you can make an informed decision before you go with that final choice.
Super, excellent. So keep staying mindful here of the time. Let's bring this to a close. So thank you, Ryan, very much. It's always a pleasure hearing from you. We are going to get this recording out. We'll have that up on the YouTube page. It's probably going to be there for maybe a few weeks or so, just not permanently. So if you do want to take a look at it, I would jump on it. But we'll send a note to everybody when it's available. And again, please, we are here to help. So please reach out to the office. If you're not a Fairhaven client, we won't give you too bad of a time, but happy to connect you with the right resources. So thanks for joining us tonight, Ryan. Thanks again. Always a pleasure.
My pleasure. Thanks everybody for taking the time.